Loretta Norton.
Yes.
Welcome to today's episode.
Thank you for having me.
Yeah, a few notes that I got when I was doing a little bit of background. Professor of neuroscience, and you lecture
King's University College.
Yeah, King's University College, and you've got interests in consciousness, death, and brain health.
That's right. All big topics.
Yeah, I think maybe to start with, I would ask, why study consciousness, death, and brain health?
I mean, there are probably no bigger questions in humanity, right?
Mm.
What happens when we die? Why are we conscious? How are we conscious? Can we define consciousness? These are just very interesting, philosophical, scientific, even religious questions. Because they kind of cover all of the gambits, right? Like all those different areas. So I think it's interesting to everyone, and certainly to me. So this is why I've chosen to kind of focus in this area.
Okay, so what would you say is consciousness then?
First hard-hitting question. So there's, when we talk about consciousness, we talk about kind of the easy problems and the hard problems of consciousness, right? So what is it like, when they talk about what is it like to be someone else or to be another animal, for example? What is their consciousness? What is their experience? Well, you can never know what their experience is, right? Like, my consciousness is something that's very private and subjective, what it's like to be me and what it's like to experience the world as I experience it. So trying to define it in those ways can be really complicated. And so, as scientists, we tackle kind of the easy problems. What are the neural substrates of consciousness? What gives rise to our consciousness? Even when we go there, that still seems like that's a really difficult problem. And it is. We haven't solved the neural substrates of consciousness, what gives rise in our brain to elicit the mind and to have, these kinds of experiences. We know some of the things and the mechanisms, but not all of them. I think that's where we need to start though, right? And so a lot of my research to try and understand these things examines people who have disorders of consciousness. So individuals who have lost consciousness, or from what we can tell at the bedside, seemingly aren't conscious. And so can we start there as an answer to, or to create some kind of understanding for a definition of what is consciousness? How do we understand it scientifically? So that's where we start, I think.
Okay. At what point maybe do you think consciousness begins, and at what point does a person lose their consciousness? Because there have been stories of where people would say someone died and maybe their heart stopped working,
mm-hmm.
but they were still conscious, or maybe, I don't know, maybe their brain stopped working, but are they alive? What's happening? So I think I would want to understand, at what point does a newborn or a baby become conscious, and maybe at what point does a person lose their consciousness?
Great questions. I'm not a developmental psychologist, so kind of looking at, babies and when does consciousness emerge, that's really difficult to answer. I don't think that there's good consensus on this. Certainly there are aspects we know in development where, even when children are born, they can discriminate in their environment with respect to some kind of visual and sound stimuli. So does that mean that they're conscious? It certainly means that they have sensory and perceptual experiences. Does that mean that a child is conscious? Then you get into kind of the whole debate about a fetus in utero and how much consciousness that there might be within those aspects, and that becomes a whole, other quite contentious topic. We can talk about even animals, right? Like, is your pet? I don't know if you're a dog person or a cat person.
None.
Oh, none. Okay, I'm a dog person, right? Is your dog conscious in the same way that a human and you are conscious, right? Does their anatomy support consciousness in the way that, and probably everyone has a little bit of a different answer, right? Some of their cognitive capacities are quite advanced, right? I'm thinking, we classically conditioned my dog to, when he needs to go outside, touch the bells on the door so the bells ring. And then we would know, he needs to go outside, so we'd open the door, the dog would go. And then the dog got really smart that I was like, if I just ring these bells, they'll just let me out. And I don't have to go, but I'm going. They're going to let me out. And so the dog's quite smart. It's quite clever. He likes to table serve, grab, knows when you're out of the room and what to snatch you're not going to notice off the dinner table. The dog is these amazing kind of cognitive abilities. You're like, it's quite advanced. But is the dog conscious the way you are? Like, is the dog reflecting on the past, envisioning the future? I don't know. And do we ever know? And so it's all these fun things that you can kind of think about. And I suppose from the science side, I probably know more about toward end of life. And what does that mean? When does someone lose consciousness towards end of life? That's where my research is. And also when people have severe brain injury. Unfortunately, we do see that quite a lot. I spend a lot of my time in the intensive care unit, critical care units, and here's where people have these really difficult conversations with families about prolonging life, maintaining someone on life-sustaining support, on life support, right? Are we going to keep the breathing machine going, or are we going to allow someone to pass away? And within these difficult conversations that physicians have with families, kind of ideas, these similar ideas emerge is how conscious is my loved one? They appear at the bedside to be unconscious after severe head injury. They may be on life support. Their eyes are closed. They don't open their eyes. Do they know that I'm here? Do they know that they're loved? Do they, when I hold their hand, are they aware that I'm in the room and I'm singing a song or I'm reading them the newspaper? Oftentimes families do ask the physician, do they know that I'm here? And that does factor in oftentimes to a decision about where to go with care. If somebody is conscious or is unconscious, is that ever used as a metric to predict and to what's going to happen to them with their recovery, or if they will continue to receive support? And the answer to that question is complicated. Yeah. Right? It is really complicated. And what we know from, about now, like 20 years of work in this field, is that with our new advanced technologies that we have, so we have some fancy equipment that we use. Yeah. What we know is that, in fact, quite a lot of people are misdiagnosed at the bedside. So they look at the bedside to be unconscious, lacking consciousness altogether. They don't open their eyes, or they don't follow the commands that a physician would give them. Oftentimes when somebody comes in, they've had very serious motor vehicle collision, had head injury, or they've had, in Canada anyways, they're shoveling their snow this time of the year, and they unfortunately have a heart attack, cardiac arrest. We see a lot of that. And the lack of oxygen to their brain renders them unresponsive. They come to hospital in coma. And they seemingly don't respond when the physician's at the bedside and the physician says, wiggle, John, wiggle your fingers, stick out your tongue, squeeze my hand. And the patient is unresponsive. They don't do any of that. And so we think that they are non-responsive. We think that their inability to respond means they're unaware. Now, with all these new fancy tools that we're using and testing that we're using, we're finding that about 20% of patients are actually more aware than what we know at the bedside. Now, in vegetative state patients, that number can be even higher. That can be 40% of people are misdiagnosed. So, I think our understanding of consciousness, just by what we're currently using, what the clinicians use, visual inspection, just knowing, are you conscious or not, I think we miss a lot of things. Because if you ask me, am I conscious? The only way that I know that Grant's conscious right now is because he's nodding and smiling, and every once in a while he's getting a in or something like that. So if somebody asks me, I say, yes, you were. But if you had a head injury and you couldn't do those things, a large proportion of people are misdiagnosed at the bedside.
Yeah, because there've been stories of where like the relatives to a person that has brain injury get to see the person maybe express emotions such as, maybe, I don't know whether it's sadness or happiness, but they would be shedding tears if maybe they're telling like a sad story. So in my head then I'm thinking, are they conscious?
Right.
Are there like proper metrics in the way that we could say if you're able to say this? And for example, in low and middle resource income countries, how do I tell that this person is conscious? Because I feel like you've mentioned that there's a lot of misdiagnosis. If, let's say, in a high-income country like Canada, there's a lot of misdiagnosis, and I would want to compare that to Africa, where there's lack of resources and lack of equipment. So is there a way that I could tell or say we could wait for this period of time because the person is then still conscious? I'm trying to figure out.
Yeah, what do we do worldwide?
How does a doctor in Africa determine?
Right. How do we do this globally? It's a great question. Unfortunately, I don't have a great answer. I think there is some things that we can do. So there are more sophisticated behavioral batteries that we should be using and we should standardize across the globe. And one of those is the coma recovery scale. It's a well-established neuropsychological tool that's used post-severe head injury. We use this in Canada. It was developed in the US, and the Coma Science Group in Belgium as well had some aspects of this. So we use that and that's a very easy tool to implement across the globe. And it's simple in certain ways, has certain features in it. Like, for example, interestingly, we often see patients who can do visual pursuit with a mirror. So if you presented a mirror in front of someone, like a little compact mirror, and if you presented it to them and you kind of moved across their visual field with this mirror, what you would actually see
is that with the eyes closed or open?
Open. Okay. So this is with eyes open. So it only works with an individual who can open their eyes. So this would be somebody who's in a vegetative state. But there's features in there that would give us some more information. Now, what do you do in a patient who's quite acute? I think we're still working in this space. This is where our new technologies are quite helpful, I think. We are doing fMRI. That's my area of expertise. So trying to get some functional neuroimaging when people are getting their structural. So when the physician wants a picture of the head with an MR machine, we're trying to get some extra images which tell us, some other things about the functionality of the brain, not just the structure. It's quite helpful. EEG. There are now starting to be some EEG paradigms that are being developed that can be helpful to identify what we're calling covert consciousness or covert awareness. That means that people aren't overtly expressing their consciousness because they are severely head injured, right? Yeah. And so they might not be able to have a motor manifestation, but they nonetheless, with EEG, can do some tasks, or with fMRI, they can just use their brain activity to do some command following tasks. And then newer technology like FNIRS, or functional near-infrared spectroscopy, also seem quite promising. And the benefit of EEG and FNIRS is it can be done at the bedside. You don't need a big magnet, you don't need a big machine. So I think some of these things will eventually get to point of care. We'll move into the bedside space, but I don't think we have, we haven't done enough in this space. We're working hard in this, but yes, technology, if we're going to rely on technology, we have to think about how we're going to resource other countries and other settings, right, to make sure that the care that they're receiving is equitable. Work to be done.
Then there are patients, people that's living with maybe post-brain injury, or they're living with a type of dementia that maybe they have all these, cognitively they're declining, right? Or they've declined, but they get to have episodes of where they become cognitively coherent. I don't know if that's an actual word. Yeah, like they just become functional cognitively. and they're able to handle certain tasks or respond carefully to a question. What's happening in that moment is, does the brain get to switch off and switch on certain parts of it? Because, for example, this person has been in this state maybe for the last 6 months, but then you have this moment. And also I think it happens like these moments of clarity, I think, when maybe someone is near death, where they're able to have these moments where let's just say something. So what's happening in the brain?
If I knew now, maybe, that would be Nobel Prize worthy. I don't know. Do you think maybe this is what I'm really interested in, right? Like, you've identified these kind of things that happen that, others have called paradoxical lucidity. And so you've identified that in different, and I mean, it does happen in dementia. The term paradoxical lucidity was only given that name in 2019, if you can believe it. It's a pretty new term to even come up with. But it is a term that has been created by a panel of experts to say just that there are these moments that have been reported where individuals who have a neurodegenerative disease, like Alzheimer's disease, other types of dementia, they progressively lose their cognitive abilities over time. They can't express themselves anymore. They lose their ability to verbally speak with their loved ones. Unfortunately, during the late stages, this can be what happens. People, lose their ability to talk and speak to their families. But nonetheless, then there are these reported moments where they've now become fluent. They are now having a conversation at the bedside. And not only are they having a conversation, so not only has language reemerged that has been lost. Now language has reemerged. It might be complex language. It also is interesting because it has other cognitive facets to it. Oftentimes they recall who they're speaking with, or recall memories from the past, or asking about someone. So, it's not just that language has reemerged, but also memory has reemerged, right? So they sustain a conversation as well. So now attention and attentional resources are online. So you have all of these kind of different cognitive domains that have reemerged in an individual. Why? And not just why, but how. How does this happen? And science does not have an explanation for the mechanism by which this happens, because you would imagine that the brain has deteriorated to the point where it can't sustain those abilities anymore. How do you have this moment in time where somebody's had a very meaningful, profound conversation with their loved one for a couple of minutes when they haven't done that for months? Why does that happen? And no one understands the mechanism behind that. Really, because the moments are hard to predict, and so you can't study those moments, right? It's hard to get you. What you'd want to do is you'd want to go in there with all that tech, right? And try and understand what's going on in the brain. I mean, I think we will get there, but it's unknown right now. So
would you say then, if a person is having that episode of mental clarity and they're able to engage with an individual, you as a healthcare professional, medical doctor...
No, not a medical doctor.
Would you be able to say then that the decisions they make in that moment would be legally binding? If, for example, they say, I want to leave this hospital, or maybe do not resuscitate.
Yes.
So
what do you do? What do you do when they say something, right? Do you follow that directive?
Yeah.
Or even in Canada, because in Canada we have MAID, which is medical assistance in dying. What if they say, I elect for medical euthanasia? Do you follow their wishes? Right? Huge ethical, It's huge ethical concerns. And I think people are starting to ask those questions. What do you do? And the answer is, I'm not quite sure. And I think, I'm not a medical ethicist, but nonetheless very fascinated about these questions and having conversations with people in philosophy and people in medical ethics about what you do in these situations. And I think the first thing that you probably have to do is assess their cognitive capacity, right? There has to be some way in those moments to assess whether you think somebody has the capacity to really make those decisions that they are in fact asking for or talking about. And if they can, if they do have capacity, I mean, I think you do follow what their wishes are in those moments, right? It's really hard to think about those questions because, again, it gets back to this idea of like consciousness. So in this moment, maybe we ascertain that they have the capacity, and so maybe we should be following their directive. What happens in an hour from now when they're no longer responsive? What do they want then in that moment? We don't know, again, because they can't tell us, but they are experiencing something, whatever that something may be, however limited it is. So what's their experience in that moment? And do they want the same thing, an hour from now or, days from now? Does that wish change? And then how do you tap into that to make sure that what they wanted, an hour ago or a couple of hours ago is what they wish for now? This is always the struggle.
I guess it actually takes a toll on their loved ones, because then you don't know how to deal with what's going on. One moment you have this person cognitively coherent, and one moment they are not there. So how do you think someone who is taking care of such a person should, because I guess at some point you have to give yourself some sort of grace and say, this is out of my control. But how can someone get to a place where they're saying, okay, this is what's happening and I need to accept? And this is a person they've known for a period of time. There's always that attachment. How does...
Yeah. Wow. It's hard to know, right? It's hard to know what the right thing is to do. I mean, hopefully people all have advanced directives. So they've all had these hard conversations with their families. So that families really do know their previously expressed wishes. What do you do in those moments? If somebody has the cognitive capacity, do you follow through with those wishes? I think if you've assessed it and a physician has assessed it, you try to honor wishes. But I think from some of the research that I've done in this area, I'm working on a scoping review now about this with families and their perspectives, what we see is that families are usually find these moments with positive emotion. Like they feel good about having this moment with their family member, but not always. I mean, and I think it's important to highlight that about 20% of cases, families are very distressed and have quite a negative emotion to these experiences with their family members. So I think it comes back to, yes, we're not just caring for the patient. Certainly we're caring for the individual with advanced dementia, but I think everyone has to realize that there is a whole family that's affected by these things, right? And so I think physicians need to be aware that these things do happen and how to talk about it with families so families are prepared or understand. There needs to be more education. There needs to be more training. There needs to be an awareness that not all families experience this moment as paradoxical lucidity. Not everyone experiences this in a positive light. And so how do you provide support to a family member who has experienced this? So I think that's
and I guess you have to think, as a physician, you're now thinking, at what point do I start recommending palliative care for that, so that they prepare maybe if they're going to lose this person, right? So there's always the dilemma: is the person going to reach consciousness? And if not, at what point do I start to?
Right. When they see this kind of moment, they think, does this mean
recovery,
that, maybe? Right? I mean, I think just that can be distressing for families. And that's why scientists like myself need to keep trying to understand the mechanism. Like this is what we offer, right? Trying to understand the why and the how. Why did this happen? How does this happen? That will provide some more answers to, is this going to happen again or not? Can it? We need to study these individuals who have an episode of lucidity to understand how frequent those moments are. In literature, the literature is very sparse on this topic, right? So don't have a good way of assessing these things, and we need to do that. Now you're tying that into terminal lucidity, which people are starting to think, I don't know, there's different camps, whether this is the same thing or a different thing, because in a similar way, people who are near death, and it doesn't have to be from dementia, but it has been reported, for example, in cancer, in oncology patients, where they've become unresponsive near end of life. Now, all of a sudden, and oftentimes hours before they pass away, they awaken, they have an episode of lucidity. And again, what does this mean for families, and how do families, maybe they're already in palliative care, now families are like maybe they are doing quite well and they might recover from this. What does this mean? Terminal lucidity is also something we don't understand very clearly. We don't even know if, paradoxical lucidity and terminal lucidity are in fact the same thing or not. What gives rise to that? Why does it happen? Is it comforting for families? Is it distressing for families? These are all the things that, it's interesting to me as a scientist, right? I want to understand the mechanism, but it isn't just the science here. We have the social issues that relate to this as well. This affects many people, not just the patient, but their loved ones too at end of life.
Yeah, that's interesting. We are talking about terminal lucidity now. So, the stories and you'd find this like almost everywhere on YouTube, where people say, or some doctors would say, this patient had a near-death experience, and people would say things that they saw after they, died a little bit, right? And they come back to tell those stories, and some of them, it becomes life-changing, at least based on those stories, and some of them still end up having all these questions, what actually happened, right? So I don't know, as a neuroscientist, what are your thoughts on near-death experience? Is it real? Is it some sort of lucidity? Is it spiritual, maybe? Yeah.
It's so interesting to think about, because it has all of these dimensions, right? Even the spirituality component to near-death experiences. First of all, is it real? If people are experiencing something, then it's real. It's real to them, right? It's real to them. So I'm of the camp of it's real until we can say definitively it's not real, and I think that's quite difficult to study. Again, it's very difficult to study near-death experiences because we don't know when they're going to happen, and so you can't set up a scientific way to measure these things, although some have tried. Those that have tried there's been some really elegant studies about, placing things in the resuscitation bay so that people who come in and get resuscitated, they place them quite high up in the room, so that if they had this feeling of rising, some would have been reported as kind of these out-of-body experiences where they're looking at themselves maybe from high up. People have reported, other researchers have tried to design things in resuscitation bays where they place objects quite high up in the room so that, then we would have a very objective measure of their experience. Because if you're laying in the bed, you won't see these objects. And the only way you would see what was placed high in the room is if you were actually floating from above the bed. That's quite clever and an elegant design. And they didn't find anything. Even in the people who reported a near-death experience or an out-of-body experience in this resuscitation bay, they didn't, they would explain their experience, but they didn't actually recognize the objects with any certainty. So it's really challenging to design a study. How do we study this objectively? It's a great thought experiment. I think going back to studying, and what we do is try to find an alternative hypotheses for things as well. Rule out things or rule them in. I don't know. So we're studying patients during the dying process. When we have a patient who's on life support and there's been a decision by the family to remove said life support because the patient is not going to have a meaningful recovery, they elect to remove support and let the patient pass away. In those instances, we approach those families and we ask them if they would be okay with us studying what happens in the brain during this process. We don't interfere in any way other than we put EEG leads on their head to look at brain activity during the process. And then we record all the other physiology. So we record their heart rate and their blood pressure and their oxygen saturation, and then we record their brain activity. And we do this while they're dying, when the ventilator and life support's been turned off, and into the postmortem period for about 30 minutes. And we can look at brain activity during this time. That's it. That's an objective way to measure what's happening, right? What is activity in your brain doing while you pass? Now, what do we see? In a proportion of patients, not all patients, in a small proportion, not too small, 20% of patients, we see an increase in activity for a very small moment of time right before the blood pressure stops. But the increase in brain activity, on the order of a minute or two. The increase in activity is in a frequency range that could be synonymous with cognition or some kind of experience. And I'm not the only one who's seen this activity. There's not many, but there's quite a few other scientists who've reported this phenomenon as well in different handfuls of patients. What does it reflect? Well, some people say just this. This is a near-death experience, right? Because the increase in activity, which means the increase in the rate of those brain waves, is fast. It all of a sudden, for 1 or 2 minutes in a small group of patients, the brain waves go quick. So could be that this is brain function that results in some kind of cognitive experience. Maybe this, life flashing before your eyes has been proposed, these kinds of things.
Or maybe you're dreaming.
Could it be dreaming? What is it? And we're just starting, because my first paper came out, not 10 years ago, right? So this is a very new, and my paper was the first one that used EEG, right? So this is a very, very new field that we're just stepping into to try and understand function and try and understand brain activity. This is where science needs to go. We're starting to answer these questions, but we're not there yet. So maybe we have a podcast in another 10 years and I can tell you so much more. Do I think it's an out-of-body or near-death experience or cognition? I don't know. I don't think so, because why doesn't everyone have it?
Yeah.
Right? There's nothing unique. We've gone through the data trying to find what's unique about these cases. We can't seem to find a similar thread in these patients. Why do some get it and not others? We have looked at, is it that we gave one particular kind of medication to these patients? And so it's that medication that's changing. That's not it. Is it the heart? So something in the heart causing something in the brain. There's no relationship there. What could it be? It could be something physiological, like this is the membranes just collapsing and the ions in the cell and out of the cell just kind of going. So there could be like a biological mechanism for this that quite explains it well, but we don't know. And I think science will get there, because right now I'm understanding brain activity, but I'm not understanding brain function. So does this activity, these really fast waves that I see for a minute or two, mean that someone's conscious? I can't say that. We can't relate the activity to the actual function yet. And I think, I know that's where we're going, because that is what my research is moving toward.
Yeah, and I think when we get there, then at some point we'd have to change how we define death, I guess. Because does a person die when their heart stops functioning, or does a person die when there's no brain activity? Then those become the questions. I don't know, and I'm curious to know what happens in the future, because right now, what is death basically? Right now, in the science world, what is death?
It's such a good question. How do we define it? It has huge implications for the legal definition, because we have to declare someone deceased, but also has implications for organ donation. So in Canada, there's 2 ways to die. Everywhere there's 2 ways to die. Legally in Canada, we have these 2 different ways. So we know that the brain can die. Unfortunately, people can have some kind of injury that causes brain death. Brain death in Canada is defined as the absence of function of your brain stem. Other places need whole brain death. You need to have not just your brain stem, which supports survival, but also cortical activity. But nonetheless, there's brain death. And then there is cardiocirculatory death, where the heart stops. If your heart stops, eventually the blood will not pump to your brain, and your brain will stop as well. This becomes kind of this challenging area, because we know that people can have a cardiac arrest. We see out of hospital cardiac arrest, right? People shoveling that snow and collapse also can get CPR. We have CPR.
Cardiopulmonary resuscitation.
Cardiopulmonary resuscitation. Thank you. So we have CPR and defibrillation now, right?
Yeah.
With the advance of defibrillators, which now we can find in like shopping malls and all kinds of places where you can access AED devices, people survive after a cardiac arrest much more than they used to survive, right? So we know that they may have actually been deceased, can be resuscitated and survive. And we know that the tissues in the body can also do that as well, right? So this is why people can become organ donors after they've died, because those tissues can be reanimated and can be used, right? We can have people donate their organs, kidneys, livers, these kinds of things, so other people can survive. A truly altruistic thing to do at the end of your life, to give somebody else life. But making sure we have good definitions of death and understanding the biology of death is so fundamentally important, so that we preserve trust in those policies and procedures, so that we know that organ donation is done correctly. We know we're not harming individuals. We know we're following the law with respect to what is our definitions of death. And so we need to continue to research this and understand the biology between what happens in the brain in comparison to the timing of what happens in the heart, making sure that we're following or even we're helping to revise kind of policies.
That's going to be an interesting discovery in the next few years. I'm interested in both the political aspect of it from the legal point of view and also what the science get to say.
Globally too? Can we say that? That it's different in different places, right? So there's, speaking to some of the other fellows in the program, when we talk about life support in the ICU and the withdrawal of life support, is that something that is not something that's done universally, right? To remove life support is not something that's done universally around the world. And even organ donation policies very different, and people's willingness to accept some of these organ donation practices also very varied across different countries for different cultural and religious reasons, right? And I think maybe continuing to study this from a scientific point of view, what happens in the body, will only help advance good organ donation and medical policies in the future by doing the science. But nobody really wants, I do, but nobody really wants to do the science. It's a bit taboo. It's in every country for many reasons that just really, death is such a personal, private moment that doing science is not done.
Yeah, I think it's because there's the emotional aspect that's there. You have to think twice when you talk about organ donation, or maybe the personal wishes of do not resuscitate, because if I wished not to be resuscitated, my wife would maybe say no, I don't want that to happen, but meanwhile it was my wish, right? Because the thought around it is usually, it comes with emotional attachment. Oh, he was my loved one, he was this, so I think, and we also assume it will be painful if we do something like that to a person, because we're trying to think in a perspective that they're still a person and alive. So I don't know if we ever get to a place where more people would say, it's all right, let's do this, because there's always a component of emotions, attachment, and I don't know.
It's hard. It's certainly hard having these end of life, as you say. It's has so much emotionality attached to it, the sense of grief, the sense of loss. And, again, we kind of going back to this idea that, yes, the physician and the treating team is treating the patient, but it goes beyond the patient, right? Look at everybody else in that room as an extension of that patient, because what's happening to that individual is affecting all of their family and their loved ones and their friends. And so that makes doing research and doing work in this space that much harder to do, because It's harder to get buy-in. It's harder to get, people agreeing in these very difficult moments to let scientists come in and be a part of that. I find that often those families who agree for me to go into the room and set up and study this are those families who know that their loved one really wanted to be an organ donor and for whatever reason can't be, and really wished that in this time of grief and sorrow, that something good could come out of it. And I think that's the way I think about my work.
Yeah.
And try to reiterate this. It's like, wow, that somebody in this moment at end of life and this family was willing to let us come in and understand that process in a new way that has never been done. Like, what a gift they're giving to the entire world, right? Because everyone dies, and yet we don't understand it in the way that we understand many other physiological, biological processes in our body.
Yeah.
Like we understand so much about our body, but the actual way in which we die, which unites all of us, is just not well understood.
Yeah, I think from a scientist perspective, you're trying to solve all these problems. So even the way death is looked at is a problem that needs to be solved, right? It's a technical problem that needs to be solved, right? But on the other side, where it's your loved one who would want to be that, you're like, this is going to be painful, there's attachments, emotions. So it's then how do we get more people to buy into trying to solve the death problem? That's when we can get to a place where we say people will be willing to say, when I die, I think I'm giving my brain to science, right? Or I want to donate my heart to a person that has got issues and they still have more life to give, right? Yeah. So how do you get to a place? And I guess it's up to the scientists. How do you sell the story that this is...
Yeah, we try not, ethically we try not to sell anything. But what I would say is that some of the work that we're trying to do within our study, which is called the new part study, we are trying to understand and shape and improve, largely just improve our understanding, which then thus improves organ donation. So, for example, if we just put this out there, I'm trying to understand how, when the brain stops in relation to when the heart stops. Basically, that's what I'm trying to understand. And if the brain stops before the heart, quite a bit before the heart, then instead of declaring someone dead based on their heart, maybe we can declare them deceased based on their brain. Why does that matter? Well, if that's true, that you have no consciousness and you're brain dead before the last blood pressure reading, while you're undergoing the withdrawal of life support, then maybe we can procure organs faster. Yeah. Maybe we don't need to wait 5 minutes, right, after. So in Canada, we wait 5 minutes after the last blood pressure. But if your heart is, so if it's 5 minutes here, but if your brain stops here and the science can show that, then maybe we go to lawyers and we go to ethicists and we present our case and we say, listen, actually, you're usually waiting until this point, but we can wait. You can actually probably definitively say it's here.
Yeah.
Now what happens? Well, you get way more organs because they haven't had this lack of oxygen for this long time. You're going to be able to maybe get a liver and 2 kidneys instead of just 1 kidney, or 2 kidneys and not get the liver. So you're going to be able to do that, which is an amazing thing. You can think of it and extrapolate that across the globe. Wow, wouldn't that be amazing? Alternatively, maybe we're saying, well, we wait this amount of time, but we've done the research and now we need to wait just a little bit longer.
Yeah.
Okay. I don't think the science is going to show that, but nonetheless, if that was the case, then all we're trying to do is to protect the donor and the person who's donating their organs for a little bit longer. And I think donor families would also appreciate that, right? That we've done the science to really maintain the trust in the process. I mean, I think, it's a good thing to do, right? I also think there's just, even if we move outside of the organ donation, because it's pretty contentious and, that's can be contentious for a lot of people. But just understanding what happens when someone dies and what death looks like and what happens in the brain and how long is someone conscious for after their last heartbeat. I'm holding my grandmother's hand, and how long does she know, like, I'm here, and how long shall we wait, and what shall we do, and should I speak with her throughout this process? Can she hear me? All of these kind of things, and understanding these things can bring comfort to families so they know what to expect when their loved one passes away. Because oftentimes we don't know what to expect. So if we can show the science and say this is what death might look like, sometimes that brings comfort too, right?
Yeah. Professor Loretta Norton, thank you for coming to today's episode, and hope in the next 10 years we get to chat again.
We'll catch up.
And see the new developments in science. Otherwise, thank you very much.
Thanks for having me on.